you know they'll watch it. And did you hear that then? Like, did you watch it?
There you go. Okay, so chapter 17 is drugs that affect blood clotting. So some general stuff to talk about first. A blood clot is blood that has been converted from a liquid to a solid. We've already talked a lot about how in other classes and stuff too, how blood is sticky, right? So it tends to clot or clump together kind of like a snowball. Thrombotic events are dangerous clots that block the blood flow. They can cause tissue damage because of a lack of oxygen to the tissues. Because remember, if it's a blood clot, it's going to be sticky. If it's large, it's a blockage. Okay, it disrupts the blood flow. Blood carries oxygen and nutrients. So if I'm disrupting the blood flow, I'm not getting oxygen and nutrients to the tissues. Anticoagulants are drugs used to reduce clot formation or prevent an existing clot from getting bigger. Okay, so they reduce clot formation or they stop a clot from getting bigger. They do not dissolve existing clots. Okay, the medication that dissolves existing clots are thrombolytics, and we'll talk about those as well. So for a normal, healthy person, the body is able to prevent continuous bleeding by forming clots. We need to clot, right? If I gash my arm open and it's bleeding, I eventually want that to stop, right? So my body needs to clot. A clot is blood, like I said, that has been converted from liquid to solid. So the way that clots are formed, we have platelets and plasma that stick together when thrombin activates fibrinogen to form fibers. It's called a clotting cascade. And if you look at page 300, there's a huge illustration of the clotting cascade. You don't necessarily have to memorize all of that stuff, but just know it's like a positive effect. Okay, so I have platelets that are triggered to stick together because thrombin activates fibrinogen to form fibers. So I have a clot. A thrombosis is when a clot forms in the vascular system, like in the vessels somewhere. This is usually triggered by atherosclerotic plaques. So a blood clot, if I gash my arm open, is great. I want that blood to clot so that my arm is not profusely bleeding, right? But a thrombosis is a blood clot kind of just where I don't want it, right? I don't want my blood to clot in the vessels because then it can circulate with that snowball effect and get bigger and bigger and bigger until it gets to a small vessel where it blocks. Yep. A coronary artery thrombus causes a heart attack. Okay, where did we say our coronary arteries are?
In the heart.
In the heart. So they are the arteries that supply the heart with oxygen and nutrients. So if I have a coronary artery thrombus or blockage, I have a heart attack, myocardial infarction. Venous thromboembolism in the deep veins, like in the legs, because the leg veins are very large, can travel to the brain or lungs if they break off. And if they travel to the brain, I have what? A stroke. Yeah. If they travel to the lungs, do you remember this one? Pulmonary embolism. We don't talk about that one as much as we talk about heart attack and stroke. So again, dangerous clots are called thrombolytic events or thromboses. Okay, patients who have had surgery or dialysis or who are bedridden have an increased risk for thrombosis or thrombolytic events. They happen when a clot or thrombus forms in the cardiovascular system somewhere, like in the blood vessels, arteries, veins, etc. This process is usually triggered by that atherosclerotic damage to the vessels. Okay, and then we have, like I said, what we call a deep vein thrombosis. Those are in the deep, big veins of the legs, or we have a coronary artery thrombus. So they cause, they go to different areas, and as soon as the vessels narrow, they cause a problem. So a thrombosis is when the blood clot is attached to the vessel, right? An embolus is when it breaks off and starts traveling. Okay, that's when it gets dangerous. If it is still stuck to, like, attached to the vessel, then we don't like it, but we're going to try to prevent it from getting bigger, try to do different things to dissolve it, etc. But if it breaks off and becomes an embolus, that's when it travels to the smaller vessels of the heart, the lungs, the brain, and we have heart attack, stroke, pulmonary embolism. This is dangerous. So like I said, blood is sticky. The clot gets bigger and bigger like a snowball as it travels through the vascular system. When the embolus is traveling, it collects more and more blood, and eventually it becomes lodged in the bloodstream somewhere because our vessels are all different sizes, right? So it gets lodged in a small spot or a small vessel and blocks it. So again, if it becomes lodged in the brain, it causes a stroke. If it gets lodged in the lungs, it causes a pulmonary embolism. And if it gets lodged in the coronary arteries, it causes a heart attack. So I've now said that like 4 times. Do you think that that's important to put in your notes somewhere? I see the look, or maybe you were clearing your teeth, but I see the look, like maybe I should have written that down. Yes.
Lungs, pulmonary, and thoughts of the heart attack, thoughts of the brain stroke.
Yes, exactly. Perfect. So an embolus, we talk about embolus being blood most often. It could also be a clump of bacteria or fat or air, but most often it's a blood clot or a portion of a blood clot, and that's what we're going to focus on in this chapter. So anticoagulants, anticoagulant therapy, are any drugs that interfere with some sort of step in that clotting cascade. They impair the blood's ability to clot efficiently. Anticoagulants decrease the ability of the blood to form clots. They are called blood thinners. Okay, this is just an umbrella term, anticoagulants, blood thinners. They don't actually thin the blood. They don't dissolve existing clots. They just prevent clots to begin with, or they prevent existing clots from getting bigger. Okay, the drugs, again, that dissolve existing clots are called thrombolytics. Okay. So we give anticoagulant therapy after like a heart surgery, or to prevent clots in patients who are on bed rest for a long period of time, or to prevent blood clots in patients who have dysrhythmias. Remember when we talked about dysrhythmias, if the heart is just kind of quivering and not effectively pushing the blood out, the blood gets sticky. It's just kind of sitting there. It's not effectively circulating. So the heart is quivering, and I have more of a chance of blood clots because, again, it's just sitting there, sticky, collecting, more and more blood. Atrial fibrillation is an abnormal heart rhythm where the atria, again, they don't contract efficiently. So it leads to higher risk for clots forming in those atrial chambers since it's just quivering. The clots can break off and then travel to other areas of the body as emboli, like we were just talking about. So when we give anticoagulants in general, again, remember this is the umbrella term, the intended response is to increase the time it takes for blood to clot, okay? Decrease the formation of clots. And I want the existing clots not to grow. They also prevent thrombolytic events like your heart attack, your stroke, pulmonary embolism. And they help maintain blood flow and oxygenation because the blood carries oxygen and nutrients to the tissues. And if I have a clot that blocks it, then I'm not getting that oxygen and nutrients to the tissues. Okay. So before we give any medication, period, right? We really want to know their vitals. But if I'm giving a medication for anticoagulant therapy, I want to know their heart rate and their blood pressure. And I want to know their baseline coagulation studies. Okay, baseline coagulation studies. So I want to know how fast their blood is clotting. You can see your coagulation values on page 302 in that box. You are not going to be asked the normal ranges, but you should know that prothrombin time, activated partial thromboplastin time, and international normalized ratio are for blood clotting. Okay, so that's on page 302 in that table. So I want to know their baseline coagulation studies, because how do I know if it's effective if I don't know the baseline, right? I also want to know if they have a history of bleeding problems. Before I give any drug that affects blood clotting, I also want to know their complete list of current drugs and if they're taking anything over the counter or herbal, especially aspirin or any product that contains aspirin, or any product like ginkgo biloba or St. John's wort or St. John's wort. They seem pretty harmless. They're over the counter, like herbal medications, but they can really affect clotting. Ask female patients of childbearing age if they are pregnant, breastfeeding, or planning to become pregnant. Also determine if they have had a birth, a miscarriage, or an abortion within the past 24 hours, because that will, if there is a birth, a miscarriage, or an abortion, that is going to have the clotting cascade happen in the body, right? Because we're trying to clot off what just happened in mom's body. So if I give something to prevent blood clots, we could end up in real trouble, okay? Check patients for any bruising. Ask whether they're taking any drugs by injection, okay? If you have to give an IM or IV drug, hold pressure over the site for at least 5 minutes if they're on a blood thinner, because they're just going to continue bleeding. Okay. Use the smallest needle possible if you have to give an IM injection. Muscles are very, very vascular. They will bleed a lot. Okay. Recommendations to avoid, we want to recommend to our patients to avoid injuries that might cause bleeding. So when I think about injuries that might cause bleeding, like I think about traumatic stuff, like maybe don't play contact sports, like football is not for you if you're on a blood thinner, right? What other stuff could cause an injury that could cause bleeding?
Getting cut or something?
Yeah, getting cut by something. Be really careful with knives in the kitchen. Use a soft toothbrush. Okay, because I don't want your gums to start bleeding. If your gums start bleeding, they might not stop. And use an electric razor, right? I don't want you to nick yourself while you're shaving. Avoid activities also like contact sports that we think of more readily, but anything that could potentially cause bleeding. While I'm giving these meds, I want to monitor for bleeding. What are some signs and symptoms of bleeding other than the obvious bleeding? Bruising. Yes, absolutely. If they just start to have random swelling in certain areas, okay, because random swelling could be a sign that they're bleeding internally. I'm looking for regular bleeding as well. Bleeding could happen from literally any site, any puncture site. I'm looking for blood in the urine. I'm looking for blood in the stool. Okay. If somebody said a paper cut, but that's like really, if someone gets a paper cut, it might not stop bleeding. I had a patient in the cath lab and we had to give a medication to prevent bleeding because they were having a big issue, or to prevent clotting, sorry, because they were having a big issue. So as I gave the medication, I'm standing next to the patient, and next thing I know, I look down and my shoes are just covered in blood. And I'm like, what are they bleeding from? And I looked, she had some like scratches. We found out they were cat scratches on her hand. She was bleeding profusely from old cat scratches. Yeah, my pants and my shoes were covered in blood. So bleeding from literally anything. If they have an IV site, it's going to bleed. So we have to watch for all that stuff, signs and symptoms of bleeding. Yeah.
Which type of drug did you say?
Actually dissolving a clot is going to be a thrombolytic. And we'll talk more about those in a little bit. So I want to, again, teach them about signs and symptoms of bleeding, because most people think it's just bleeding, but it's not, right? Teach them to follow up with their medical appointments, because I want to keep an eye on their labs and make sure they're in that good therapeutic window. I don't want their blood clotting to be too slow. Okay. I just want it to be nice and thin, if you will. I don't want it to not clot at all ever. I want them to take their medications as directed, no double doses, avoid injuries that can cause bleeding, and notify doctors, dentists, or anyone that you are going to have like different therapies through about the meds that they're on. That's really important. We actually want them to wear a medical alert bracelet and everything like that too. Because if you go to the dentist and you don't tell them that you're on an anticoagulant, then they could do a dental procedure and your mouth won't stop bleeding, right? So there's potential issues there. Same with surgeries. A lot of times surgeries will get canceled or postponed if you're on anticoagulant therapy. So it's important to communicate that with your patients. They might not understand the severity of it. And that medical alert bracelet, again, very important. If you get in a car accident, I'm not on an anticoagulant. If I get in a car accident, that's probably an issue. I'm going to go to the hospital and stuff like that. If I'm bleeding, they're going to try to stop it. But if I'm on an anticoagulant and I get in a car accident and the paramedics know right away, they can take steps immediately to stop my bleeding. Because if we don't stop the bleeding, when is the bleeding going to stop? This is a rhetorical question. Well, I mean, eventually, right? Because you only have so much blood in the body. Yeah. But really, if it doesn't stop, it doesn't stop. So it's very important that you make people aware, wear that medical alert bracelet, et cetera, if you're on an anticoagulant. A lot of these people on anticoagulants, trip and fall in their house, and maybe they bump their head on the floor but feel fine. They get up and go about their day, and then they die because of a brain bleed, or like a hip fracture or something like that. They end up bleeding internally, bleeding to death. So it's very, very important. Anticoagulants are taken incredibly seriously, because they can be very deadly. Even though their benefits prevent things like heart attack, stroke, pulmonary embolism, if they're not used correctly, or if they're not communicated, then it can cause major issues. So our anticoagulant drugs, again, prevent or slow the formation of clots. We have a few different kinds. We have direct and indirect thrombin inhibitors, vitamin K antagonists, and antiplatelets or platelet inhibitors. The use is prohibited in people with conditions like bleeding ulcers, or in people who have had any surgery or birth or abortion, or what else did I say? Birth or abortion or miscarriage within 24 hours, possibly even longer. There's a table. I should have put it in my notes. But there's a list somewhere in here that talks about like absolute contraindications. Oh, that's for thrombolytic drugs. So we'll talk about that in a few minutes. Sorry. Okay. So no anticoagulant drugs if they have any like bleeding condition of any sort, or if they've had any surgery, birth, abortion, miscarriage within the last 24 hours. So our thrombin inhibitors indirectly or directly interfere with blood clotting by blocking the action of thrombin, which helps form clots. You can see the thrombin inhibitors on page 305 in that chart. Direct and indirect are both listed there, okay? The goal of these is to increase clotting time. So what do I mean by increasing clotting time?
Thinking of less time for its clot.
Yes. So they increase the time that it takes for the body to form a blood clot. To measure this, we use APTT, or activated partial thromboplastin time. So just remember APTT. I want the APTT to stay in the therapeutic range to prevent new clots from forming and to prevent existing clots from growing, so the blood can continue flowing appropriately. Again, they do not break up or dissolve existing clots. So side effects are, guess what? Bleeding problems. Because yes, I want to keep that blood flowing, in someone that has like AFib or something like that. But it's going to prevent somebody from clotting normally if they gash their arm or whatever. Heavy menstrual bleeding, if they're still getting a menstrual cycle. Hyperkalemia, what's that? Increased potassium, yes, exactly. Osteoporosis, thrombocytopenia, decreased aldosterone, alopecia, and stomach problems. Okay, adverse effects are hypersensitivity. That's like your allergic reaction, okay? Heparin-induced thrombocytopenia, or HIT, okay? And heparin-induced skin necrosis. Rivaroxaban is associated with digestive upsets. It's recommended to be taken with food. That's something specific about rivaroxaban. Heparin therapy lasting longer than a week, especially if it's the unfractionated heparin, can cause a drug reaction that activates platelets, causing extensive microclots. Okay, this is heparin-induced thrombocytopenia, or HIT. So heparin that's extensive in use causes a ton of microclots that depletes your platelets. Okay, it greatly increases your risk for bleeding, because microclots, that's a problem in itself, right? Because microclots, do you think they're going to get bigger? They're blood clots. They're sticky. They're going to get bigger. But then at the same time, all your body's platelets that are used for normal clotting are going to these microclots. So your normal clotting is not going to happen. So you're at a great risk for bleeding. So we closely monitor our platelets, or our thrombocyte counts of patients who are on prolonged heparin therapy. And we want to make sure we're watching for any prolonged or unusual bleeding. So before we give these, I want to know their weight, because we usually are going to base the dosing according to weight. Does that bring back like memories from med dosage, weight-based stuff? Yes. I want to make sure that I have protamine sulfate readily available because that is the antidote. So if all of a sudden I start to notice bleeding or signs of bleeding, I want to give an antidote right away. Okay. Low molecular weight heparin should be given subcutaneously in the abdominal area only. Okay. If you're giving them, we don't expel, there's like a little air bubble in the syringe. We don't get rid of that. Okay. And we also don't aspirate. Do you know what aspirate means yet? It is, but when we're talking about like injections. So when I'm talking about injections, it used to be best practice that we like inject a little bit and then we pull back to see if we're in a good spot. We no longer pull back. You guys probably don't even need to necessarily worry about that because it's not a good practice anymore. So you won't learn that in medical assistant stuff. But we don't get rid of the little air bubble that's in there. It's in there on purpose. And we don't want to rub the site afterwards because if I'm injecting something to inhibit clotting, that's an injection, right? A hole in the body. And if I rub it, do you think I'm going to get a big nasty bruise? Oh yeah, like a whole abdomen's worth of a big nasty bruise. Patients should consider or consult their prescriber before they take aspirin or ibuprofen because taking aspirin or ibuprofen while on heparin increases the risk of bleeding. Teach patients to read the labels of all their over-the-counter and prescription drugs to see if they contain aspirin. Because there's straight up aspirin, right, that you can buy, but there's other medications out there that are like combinations of meds that might contain aspirin. So they need to be aware of that kind of stuff. Monitor infusion rate based on orders and results of labs. So if you're giving heparin IV in the hospital setting, which some of you are going on to be nurses, so this would be you, then you need to monitor those labs to adjust IV rate. Monitor that IV site. Patients should not take NSAIDs, like I said, while taking heparin because it increases the risk of bleeding. So that includes aspirin, aspirin-containing stuff, ibuprofen. We also want to avoid grapefruit juice and store drugs in their original containers. But I feel like that should be like well, duh, for everything, right? All of your meds should be in their original containers because how do you know what it is if you move them around to other containers? So heparin is safe to use with pregnancy and breastfeeding. Heparin is the drug of choice, actually, when we're talking about pregnancy and breastfeeding. It's just important to note that bleeding problems in mom during the last trimester and during delivery are possible, but you're not going to be like dosing this on your own, right? This is going to be like a hospital setting with close monitoring. Older adults are more sensitive to the drug's effects, so they might need lower doses. Teach older adults to immediately apply cold compresses or ice packs to an injured area to reduce bruising and bleeding if they're on any medications that they're going to be like this, that they're going to be taking at home. A lot of these you can look in that chart on page 305 and you're going to see like IV, subcutaneous, IV, all of that. So those are going to be the ones that are given like in the hospital setting, or the ones that are given subcutaneous might be a clinic setting. But some of them, like the direct thrombin inhibitors, are PO. They might be taking these at home on their own. So teach them how to take them appropriately. And then we have vitamin K antagonists or clotting factor synthesis inhibitors. It just depends. Our book calls them the vitamin K agonists. And these are going to be, let's see. I don't think these are in a chart. This is on page 307 is where it talks about it. We're going to talk about just warfarin in this category. So it doesn't have a green chart. Okay, just warfarin, or Coumadin is the brand name. So warfarin, remember when I talked about meds for like dysrhythmias, we talked about like, just make a note about warfarin because we're going to chat about it next week. Well, here it is. Okay. So warfarin decreases the production of clotting factors or the synthesis of vitamin K in the liver. So it prevents clots from forming. The intended response is also to increase the clotting time. Okay. I want clotting time to be longer. But to monitor here, we are going to use INR, or International Normalized Ratio. Most patients are started on warfarin before they stop heparin. Heparin is the IV medication or the sub-Q injection that they're taking in the hospital, and then we bridge them over to warfarin before they leave. They might take both for a couple days until the INR is within a therapeutic range. Then the heparin is going to be discontinued. Warfarin is one of those drugs that has a narrow window of being therapeutic. So if you go back to that table on page 302 and you look, again, I'm not going to ask you ranges, but just for reference, the normal range or the therapeutic range for INR is 2.0 to 3.0. That's not very, very big. Okay. So that's not a huge range. It doesn't have a toxic effect necessarily, but it's very dangerous when the INR is too high or it takes too long to clot. So these people have to get their INRs checked very often, like a couple times a week, okay? And we determine dosing on whatever the levels are. If I told you that you had to go to the doctor's office to have your labs checked 3 times a week, how likely are you to do that? Yeah, our patients are not known for their compliance with this. I actually had a patient who their INR, so the normal therapeutic range is 2 to 3, right? His INR was like 12. Okay, so that literally means that if he coughed forcefully, he could have like bled to death in the lungs. His gums were just oozing from who knows what. Okay, I don't even know if it was from brushing his teeth. So just sitting there, he was at a huge risk. We sent him to a different facility, and then when he followed up, he was like, yeah, when I went to the other facility, they made me stay in bed and wear a helmet. You were serious. This is a big problem. I'm like, yes, a huge problem. Literally a splinter could have made you bleed to death at that point. So we worry about their INR becoming too high. Okay, they have to get them checked often. And his whole thing was that he just didn't want to go to the doctor every couple of days. That was a lot. So he just kept taking the same dose. So a lot of times we give them like a couple of pills and then they have to come back and get it checked again. And then we give them a couple more. So, you know, that way we can make sure they're in the therapeutic range at all times. So side effects of warfarin or Coumadin, excessive bleeding. Okay. Again, when I tell you excessive bleeding, I cannot stress to you enough how excessive I mean. Okay. Excessive bleeding, headache, upset stomach, diarrhea. I said that funny. Diarrhea, fever, rash. Adverse effects are, again, excessive bleeding and hemorrhage. Because if I have a little bit of excessive bleeding versus a lot of excessive bleeding, I don't know. I feel like it should have just been under adverse effects. I never want someone to bleed excessively. Warfarin-induced skin necrosis is rare but serious. It's a complication that usually happens in women who are obese and going through menopause. And there's lots and lots and lots of different drug interactions. We started talking about those, but the whole semester, we're going to talk about different drug interactions with warfarin. So those never go away. And just know any person of Asian heritage who needs anticoagulation therapy should be started on a very low dose of warfarin and have their INR monitored more frequently. Because of a known genetic variation, like a gene associated with warfarin or vitamin K metabolism. So just an odd fact there. Warfarin is on, let's see, starts on page 307. Let's see. Okay. Yep. So the only vitamin K antagonist we're talking about is warfarin. So it's all in that 307, 308, 309. So before we give these meds, before we give warfarin, we're going to want to know all the other drugs they're taking and research their possible interactions. I want to know their baseline INR lab results. I'm going to monitor their INR frequently. And I want a vitamin K antidote available. Phytonadione, I'm never going to say that correctly. So sorry there. The vitamin K antidote, let's just say that. I want that readily available because again, if my patient starts bleeding uncontrollably, the only thing that's going to stop it is giving the antidote. I also want to teach them to avoid large amounts of food that are rich in vitamin K. Some vegetables are rich in vitamin K, which can decrease the action of warfarin. Okay. It should be determined whether the patient is on a vegetarian diet because, again, vitamin K is the antidote for warfarin. So if they're on a vegetarian diet and they're eating lots and lots of like leafy green vegetables, That could be a potential issue. And if that's their normal diet, that's okay. I don't want them to change that. We're just going to monitor their INR and adjust the dosing, because as soon as you tell them to change it, then it's going to change what's normal for them. And then it's going to give a different effect on the warfarin. So foods that are rich in vitamin K include liver, green leafy vegetables, broccoli, and cauliflower. Drugs that increase the action of warfarin include aspirin, acetaminophen, statin drugs, oral contraceptives, some antibiotics, and there's more. We'll talk about each one of them when we get to them in class. Drugs that decrease the action of warfarin are cholestyramine, sucralfate, barbiturates. Again, we'll talk about those when we get to them. Just know for the purpose of like this exam that there are tons of meds that negatively interact with warfarin, either increase or decrease effectiveness. But there are going to be questions about food on the exam for warfarin because it is a big deal with the warfarin. So again, teach them to maintain their current diet. Okay, I don't want them to increase their green leafy vegetables. I don't want them to decrease. I want them to just maintain their normal diet. Okay, any abrupt change can alter their INR results. Medical follow-up is very important to check their INR and adjust dosing. Eat consistent amounts of vitamin K rich foods. That's on there a lot of times, right? Don't take aspirin containing products without consulting a prescriber, and avoid alcohol. Alcohol can interfere with the action of warfarin as well. And manage home safety. That sounds kind of silly, right? But really, manage home safety. If they are someone that is at risk for falling, I want to make sure there's no random cords laying around their house and that their carpet's not buckling or a rug's not, bending upwards in one side or whatever. I don't want them to trip and bleed to death. So lifespan considerations, in kids, we rarely use it. Parents should understand that their child should not receive any other IM injections or take aspirin containing drugs or participate in contact sports if they're taking the drug. It's not used in pregnancy because it can cause birth defects and bleeding. Okay. So if someone, so much so that if someone is becoming or planning to become pregnant or anything, we wouldn't give them a med. But if they're in childbearing age, I want them to use 2 forms of birth control. Women in childbearing age, like I said, should use 2 forms of birth control. In older adults, they're more sensitive. And again, we monitor that INR very closely. Next, we have our antiplatelet drugs. These are used for primary and secondary prevention of clots in the brain and the cardiovascular system. They block platelet aggregation or clumping. Aggregation just means the clumping of the platelets. Okay. Their intended response is to increase clotting time, decrease clot formation, and to prevent further growth of existing clots. They're given by the oral or IV route. Fun fact, aspirin is one of these. Even though we talk about aspirin when we talk about like NSAIDs and stuff, you can get an aspirin in a tablet, a capsule, gum, or suppository form. So there is a table in your book for these on page 310. Okay. So side effects of antiplatelet drugs are bleeding, headache, dizziness, and diarrhea. Adverse effects are a life-threatening hemorrhage, thrombocytopenia, and allergic reaction. And just remember, when you're looking at aspirin and salicylates, that's back in chapter 10, maybe. So refer back there if you need to for aspirin. So before I give these, I want to know their platelet count. That's what I'm monitoring with these because it's a little different for each of our anticoagulants. Schedule doses around antacids because antacids interfere with absorption. So give an antiplatelet 2 hours after or 1 hour before an antacid. 2 hours after an antacid or 1 hour before an antacid. And give antiplatelets with meals because they can make somebody pretty nauseous. Monitor for signs of bleeding or allergic reaction. Monitor their vitals, their labs. So again, teach your patient to take them with meals to decrease that nausea or GI effect. Avoid taking these with antacids because if I'm going to do anything in the clinic setting or the hospital setting, I'm going to teach my patient to do the same thing if they're going to take them at home, right? Treatment here might be lifelong. Do not stop the drug unless the doctor tells you to. So Lifespan considerations, taking antiplatelet drugs during the last 2 weeks of pregnancy can cause bleeding problems in the baby before and after delivery. So we definitely want to have that closely monitored by the physician. They'll probably have the mom come off of these meds. It is excreted into breast milk, so we don't want mom to breastfeed. And aspirin and NSAIDs should not be taken during the last trimester or while breastfeeding in general. Next, we have our thrombolytics. These are the ones that actually dissolve the clots, okay? All of the other ones only prevent a clot from getting bigger or prevent clots to begin with. Thrombolytics are the only ones that dissolve existing clots. These are your clot busters, okay? They're used to treat heart attacks, strokes, pulmonary emboli, and other clot problems. The intended response is to increase clotting time, dissolve existing clots, and prevent or minimize tissue damage. Okay, these are in the box on page 312. And if you look at them, there's going to be dosing. You're not going to memorize dosing, okay? But there's dosing for an MI. What's an MI? What's a myocardial infarction? Heart attack, yes. Okay, so there's dosing for an MI. There's dosing for a PE, which is your pulmonary embolism, and then there's dosing for a thromboembolic stroke. Okay, so those are the 3 big problems we talked about, right? Heart attack, stroke, and pulmonary embolism. So these are given in an emergency situation if you have one of those things. These are not given to take at home. These are all given IV very specifically, probably in the emergency room or ICU setting, okay? They're used to treat heart attacks, strokes, pulmonary emboli. Their intended response, again, increase clotting time, dissolve existing clots, and prevent or minimize tissue damage. If they're started within 12 hours after the onset of symptoms for heart attack or 3 hours for stroke symptoms, they can dissolve the clot that's blocking the artery and restore blood flow. The sooner these drugs are begun, the more likely they will achieve a positive result. Okay, our patients here, they're in like a potential life or death situation. So I'm giving these meds to hopefully save their life. Side effects are bleeding or oozing from cuts. Okay, this is, like I said, my lady in the cath lab, we gave it to her for her heart attack, and she was bleeding profusely from everywhere. Her Foley catheter was full of blood. The bag that collects the urine was just full of blood. Her IV site was oozing. Her cat scratches on her hand were just oozing. Literally blood everywhere. I think we were all covered in it by the time the case was over. She lived. Okay, so that's what matters. She lived and I threw my shoes away. So yeah. Yes. Yep. We absolutely give them an infusion of this. We start the infusion and bring them to the cath lab, and the infusion is still going despite the fact that they're bleeding literally everywhere. So again, side effects, bleeding or oozing from cuts, from their gums, from any wounds, from any injection sites, literally everywhere. Fever, low blood pressure, adverse effects or allergic reaction, life-threatening hemorrhage, and hemorrhagic stroke. So anywhere that is clotted, the clot will dissolve. With all of the other meds we talked about in anticoagulants, they're going to prevent a clot from getting bigger. They're going to prevent new clots from forming. But, bleeding is a risk if you fall and hurt something because you're not going to clot. But if you have a scab somewhere, it's not going to just dissolve your scab and all of a sudden start bleeding. Thrombolytics will. Anywhere there's a clot, the clot will dissolve and they will bleed. Okay, so there's that table I talked about, or that box on page 313, absolute contraindications for thrombolytic drugs. So even if the patient has a heart attack or a stroke or a pulmonary embolism, I cannot give a thrombolytic drug if there's active internal bleeding, if they have had any type of surgery, if they have had another stroke recently, okay, if they have a high blood pressure, if they have a known bleeding disorder, if they've had a pregnancy or recent delivery, if there's prolonged CPR, if they've had a recent trauma or suspected aortic dissection, any of that stuff contraindicates it, no matter what's happening to them. Okay, hemorrhage is a major risk when patients receive thrombolytic therapy because the action of these drugs is to break down clots. Let's see. So before I give it, I want to know what meds they're on. I want to know that the presence of any of those absolute contraindications. Okay. And I want to know their coagulation lab tests. I want to make sure they have IV access because I'm giving these IV. I want to monitor for signs of bleeding. I want to monitor their coagulation lab tests, assess for headache, assess their level of consciousness, and don't give any other injectable drugs. I don't want, if I have an IV in place, I don't want to take it out. I don't want to start a new one. Okay. Leave everything in place. Again, look for those absolute contraindications. Once the patient's discharged, they should notify once the drug is discharged, they should notify the prescriber if any of these conditions develop. Fever, shortness of breath, changes in the arms and legs like blueness, swelling or feeling cold, signs of bleeding, lightheadedness, dizziness, nausea, back pain, all of that. So these meds are given short-term in an emergency situation, but they can have lasting effects. Teach your patient all of that stuff that we just talked about. Lifespan considerations, these again are only given in the hospital setting, so there's no priorities to teach patients about as far as taking these drugs at home. Okay, just like signs and symptoms to watch for after they've had the meds. Problems with IV access sites can include bleeding, swelling, pain, or numbness, and any signs or symptoms of an allergic reaction. Delivery of baby, miscarriage, or abortion within the last 24 hours is a complete contraindication. And as far as lifespan considerations, pregnancy and lactation, they're at an increased risk of birth defects, particularly during the first 5 months of pregnancy. But again, we're talking life-threatening stuff here. And then we have colony stimulating factors. We use these in patients with kidney failure and for cancer chemotherapy. These are in the box on page 314. Sometimes drugs are needed to improve the ability of the blood to clot rather than decreasing clotting. So all the other stuff we're talking about decreasing clotting. Now we're talking about promoting clotting. Okay. I would want a patient with kidney failure to clot better because the kidney senses oxygen levels in the blood. When the levels are low, it secretes erythropoietin into the blood, and this substance goes to the bone marrow and stimulates it to increase the production of red blood cells. So if I'm having issues with kidney failure, I don't have that sensation to create more red blood cells. Okay. So let's see. The intended response of these is for the blood cell numbers to come to normal and to reduce the need for a blood transfusion. So again, we increase the red blood cells and we increase platelets here. Side effects are more viscous blood. What is viscous?
Thick.
Yeah, like thick, like sticky. Okay. Tenacious is sticky, but more thick blood. So if I have more viscous blood, it can raise the blood pressure. It can increase clot formation. It can move slowly through the small vessels. It might cause headaches, general body aches, flushing, fever, chills, and pain where it's injected. These are injectable. Adverse effects are severe hypertension, blood clots, stroke, heart attack, and increased growth of certain cancers. The basis of dosing these is to monitor individual hemoglobin levels or platelet levels to ensure that enough cells are produced to avoid the need for a blood transfusion. So patients should be asked whether any allergic reactions or difficulty breathing happened if they've had previous doses. Okay. If their platelet levels or hemoglobin levels are not appropriate, like too high, notify the prescriber before we give the drug. Ensure that oprelvecin is administered only by deep sub-Q injection, not IV or intradermally. You don't necessarily need to remember that because I'm not going to ask you questions like that. And then watch for potential signs of blood clot, like swelling in an extremity, difference in skin color or temperature in one extremity, pain in one extremity. Watch for signs of heart attack or stroke, like chest pain, shortness of breath, change in level of consciousness, difficulty speaking, numbness or drooping on one side of the face or blurred vision. Oh, what? Sorry. Where was I? Okay. And then teach your patient to weigh themselves daily, especially right after treatment. Some people get these treatments like a couple times a week. Did you have a question or are you stretching? Okay. So if they're getting these multiple times a week, then they would need to monitor their weight, report a weight gain of more than 2 pounds in 24 hours. report any abnormal signs of clotting, call 911 for signs of heart attack or stroke. Excuse me, thank you. Sometimes they're going to be learning how to inject themselves at home, especially if they're taking them a couple times a week, like before dialysis treatment. So teach them how to inject themselves, and follow up on all of their blood work. We don't really know how this affects pregnancy and lactation, so we're going to weigh the benefits versus the risks and use it if we need to. Okay. Older adults should be monitored more closely for blood cell responses and should have therapy stopped or decreased if their hemoglobin gets too high. In our older adults, hypertension is likely, and they're at an increased risk for congestive heart failure, pulmonary edema, and heart attack or stroke. So again, monitor more closely. All right, and that is it for chapter 17.